All right, guys, it's 7:05. We're going to go ahead and get started. Good morning, everyone. Welcome to the first Head and Neck Live of 2023. Today, we have a very special speaker. And so Dr. Eric Lamarre will be introducing her.
Thank you, Dr. Jamie Koo. It's my pleasure to present Danielle Bottalico. And so just a little bit about Danielle for those that have not had the pleasure of working with her. She grew up in Poughkeepsie, New York, and attended McGill University in Montreal, where she received her Bachelor of Science in Anatomy and Cell Biology. Afterwards, she moved to New York City, close to Poughkeepsie, to work at Albert Einstein College of Medicine, researching HPV and oral cavity. Prior to attending medical school, she obtained her Master's of Public Health at the City University of New York School of Public Health at Lehman College, with a focus in geographic information science. She was a member of the inaugural class of the Frank H. Netter School of Medicine at Quinnipiac in Camden, Connecticut, and completed her residency at Albert Einstein College of Medicine, Montefiore Medical Center. She's now over midway through her fellowship at Cleveland Clinic in head and neck oncology and microvascular reconstruction. And for those that have not had the pleasure of working with her, she's a tireless surgeon, also a patient favorite, and uniformly a strong resident advocate. So without further ado, present Dr. Bottalico.
Well, thank you all for having me. That was a very kind introduction. Today, I'm going to be presenting on taking a pre-treatment timeout, the importance of frailty assessment in head and neck cancer patients. So I have no financial disclosures or conflicts of interest, but before we get started, I just want to talk a little bit about how did we get here? Why am I presenting on this topic, to give you a little bit of context? So as you heard in the introduction, I do have a background in public health. I spent a lot of time in graduate school learning about the epidemiologic transition and how this has contributed to rising cost of healthcare. And I also spent time studying low value care from a systems-based approach. So when I began medical school and then went on to residency, I brought this past experience with me, but I also started to look at healthcare from a more patient and physician-centered focus. I noticed that as physicians, I think we all genuinely really want to help our patients, and non-maleficence and beneficence, I believe, serve as all of our core values, whether we're practicing medicine or a surgical subspecialty. We always want to find an answer. And I think we can become so immersed in what we do and wanting to do good. It can be really easy to divine our professional identities with this idea of curing of disease and triumph over illness. I've sat through a lot of conversations now between physicians and patients, and I'm even starting to have some of those conversations myself this year. And I've always been really impressed with the time doctors take to explain disease processes and surgical procedures to patients. But I often wonder, because I'm listening with a medical background, if our expectations align with the patient's expectations. There are always those patients in the hospital that I remember seeing where, as you sort of, maybe their course was prolonged or complicated, and you kind of watch their morale decline each day as you go in and see them. Or maybe you think they had a really great outcome, but they're really disappointed with the way their speech is, or that they can't swallow the way they used to. I actually just saw a gentleman the other day in my clinic that I did a trach on here. He had a history of supraglottic squamous cell carcinoma, now with squam of the cervical esophagus, and lung cancer with distant mets, the brain. And when he came in, he had bilateral vocal cord paralysis, and we did a trach on him. He begged me for the trach. And then I saw him just a couple of weeks ago in my clinic, and he was crying, and he told me that if he had known what it was going to mean to live with a trach, he would have rather to die. So I felt really bad in that situation because I felt like I had spent a lot of time explaining what that meant to him, but clearly what I conveyed was not what he imagined. So in short, I wanted to kind of incorporate my past educational background and explore some of these personal observations and experiences I've had more objectively from an evidence-based approach to see if we can maybe find some way to predict poor outcomes and possibly even decision regret in our patients. So these are the three learning objectives I hope we'll accomplish by the end of this talk. Understand the aging population and the impact this will have on head and neck cancer incidence. Define frailty and identify validated frailty assessment tools, and explain how frailty can influence low value care and impact clinical outcomes and decision regret. And we'll do this by going through this outline. So I first want to start with a case presentation. This is a real case from my fourth year of residency when I was rotating at one of our satellite hospitals. And this patient in particular kind of motivated me to look a little bit deeper into this topic. So he's an 85-year-old male. When I came on service, he had initially presented from a nursing home with shortness of breath and stridor. He underwent an emergent awake trach and a DL biopsy, and he was ultimately, after complete workup, diagnosed with T4A and 2C clottic squame. He has a pretty significant past medical history, dementia. He was oriented to person, but not time or place. He had COPD, diabetes, hypertension, hyperlipidemia, coronary artery disease, and heart failure. So I just want you to think about this patient and think about a few things to keep in the back of your mind as we move through this talk. And remember, there's absolutely no right or wrong answer. But for this gentleman, what treatment options might you consider? What would you tell him, or how would you counsel him in regards to his chance of cure? If he were to undergo treatment, what would you predict his length of hospitalization to be? How would you counsel him with regard to his ability to speak or eat? And what might you tell him in respect to what could go wrong if he did undergo treatment? And then lastly, in any circumstance, would you ever consider no treatment for this individual? So to start, let's discuss the aging population and how this is impacting head and neck cancer incidence. So I first want to introduce this concept of the epidemiologic transition, which many of you may already be familiar with. But essentially what this is a theory that describes a shift away from infectious and chronic disease as the primary causes of morbidity and mortality in developed countries. And essentially what it illustrates is the evolution of neoplastic disease in the setting of increased life expectancy. So what's happening to our population in general? Are we getting younger or are we getting older? Well, we're definitely getting older. Between 1980 and 2000, people 65 and older increased by 10 million. This is projected to double in growth to 72 million by the year 2030. And why is this important? Well, this is important because we know that age is the single most important risk factor for cancer overall. Between 2010 and 2030, there's expected to be a 67% increase in overall cancer incidence projected for patients 65 and older. So to look at the epidemiologic transition in the context of head and neck cancer. So many of you may be thinking, well, we're having this rise in HPV positive cancer and this characteristically affects younger patients. But despite this, head and neck cancer still remains a diagnosis of a disease of older patients. It's currently diagnosed in an estimated 635,000 people worldwide, and 49,000 of those cases occur in the US each year. Approximately half of the patients who are being diagnosed are 60 years of age or older, and 21% of that half are older than 71. By the year 2030, we're expected to see 61% of our patients will be 65 years of age and older. And I think this is a particularly important fact because older patients are historically underrepresented okay, or excluded from clinical trials which define current standards of care. So only 3.4% of current studies globally involve patients older than 65 years And there was a recent meta-analysis of head and neck cancer patients who were undergoing chemotherapy. Only 4% of those patients across 93 clinical trials were older than the age of 70. So I think this is just an important point because as the proportion of our patients gets older, it's going to become increasingly important to understand the goals of these patients and their caregivers, as we don't really have high level evidence to support treatment models in this population. So now to discuss a little bit about survival rates and low value care. When we talk about survival rates and prognosis in our cancer, head and neck cancer population, we can think about it in terms of the good, the bad, and the ugly. So the good, we have noticed some improvements, and we can attribute these improvements to the increased incidence of HPV-related oropharyngeal cancer, as I mentioned earlier, advances in multimodality therapy, targeted therapy, IMRT, and immunotherapeutics, which are currently undergoing clinical testing and showing some promising developments. But the bad news is that over the last 30 years, survival rates have demonstrated only marginal improvements. 5-year overall survival rates are reported anywhere between 40% and 60%. And what's even worse is that recurrent or metastatic head and neck squamous cell carcinoma remains a lethal disease with the median overall survival less than 12 months. So how are these marginal improvements in survival rates related to low value care? So first, I think we have to define low value care. And there's two ways that you can approach low value care. The first is a systems-based approach, which I studied a lot during my public health education. And this is where overuse in healthcare is defined as services in which patient and potential harms exceed the benefits. But I think from our standpoint, patient-centered approach is really important, and this is where treatment modalities fail to meet the goals of our patients. So to first look at this from the systems-based approach, despite the introduction of the Medicare hospice benefit in 1983, care for patients at the end of life comprises more than 25% of Medicare expenditures. And 1% of patients account for 20% of the expense. Between 1978 and 2006, we've noticed an increase in trends of multiple hospitalizations and the use of ICU units in the last few months of life among Medicare patients. And there has also been this reported trend of increased aggressiveness of inpatient and cancer care near the end of life. So this here is a graph that represents clearly how expense increases exponentially with age. And you can see how the US fares a lot worse than other developed countries. And as you can imagine, based off of the statistics I presented earlier, as our population continues to get older, the continuation of this trend remains unsustainable. So now I want to look at low value care from a patient-centered approach. So approximately a third of elderly Americans will undergo surgery during the last 12 months of their life. The majority of these interventions actually occur in the last month of their life. This is in general, not specific to head and neck cancer. There was a survey of Americans who were older than 60, and 75% of them reported that they would not elect to undergo surgery if they knew they only had a year left to live. So I think bringing the systems-based approach and the patient-centered approach together leads us to this idea of the paradox of plenty. So there's substantial geographic variation in the utilization of Medicare services throughout the US. Provider behavior varies greatly even within a particular region. And dollars spent per patient are not consistent. The cause of all of this remains controversial, but what we do know is that there's no evidence that aggressive treatment has any benefit, and correlation between healthcare expenditure and healthcare quality remains very small. So how are we currently treating our patients? We'll just briefly go over this, as I'm sure most of us already know, but for early stage head and neck cancer, we're treating these patients with unimodality therapy, so surgery or radiation alone. But even still, these patients require routine surveillance to look for potential recurrences and detect second primaries, with the majority of recurrences being observed within the first 3 years of initial therapy. When we talk about late stage disease in patients with local regionally advanced disease, combined modality therapy is what we need to optimize tumor control. This can include surgery, radiation, and or chemotherapy. And nevertheless, despite the fact that we give curative intent treatment, more than half of these patients will relapse with local recurrence or distant mets. And as we mentioned before, this can be a devastating diagnosis with median overall survival less than a year. In certain cases, there is a small chance for successful salvage treatment with surgery or irradiation. There have been some studies that have looked at chemotherapy, radiation, and targeted molecular agents when used for palliation of symptoms, and they've shown to have little efficacy. There was a multi-institutional study of chemotherapy that was used in end-stage cancer, and palliative chemo was shown to have worsened the quality of life for patients who started out with good performance scores, and it had no benefit for patients who had moderate or poor performance status. So this brings us to how do we define and how can we assess frailty? So first, let's define frailty. Frailty is a concept that was developed by geriatricians. The precise definition remains a bit elusive, but it's agreed upon that it's a global syndrome of decreased endurance, strength, and physiologic reserve, which is characterized by an elevated vulnerability to stressors. So it's distinct from, but it often overlaps with a patient's age, comorbidity, and or disability. And it's an independent determinant of health status. So frailty includes 6 domains. It looks at physical performance, gait speed, mobility, nutritional status, mental health, and cognition. And it's been shown to be an independent determinant of health status. It's associated with an increased dependency and or death. And what's also important is that it's not captured by our standard risk stratification tools like ASA or EAGLES criteria. So there are currently 2 competing frailty hypotheses or theories described in the literature. There's the frailty phenotype and the accumulation of deficits theory. You might be wondering at this point, well, why are we even talking about frailty? Why don't we just use traditional oncologic measures that we commonly see reported in the literature and we see in all of our clinical notes, such as the Karnofsky Performance Scale and the Eastern Cooperative Oncology Group Performance Status, or ECOG. These instruments have been used to assess functional status. However, they're actually not validated in the elderly, they're subjective, and they don't capture information regarding comorbidities and physiologic impairment. So first, let's talk about the frailty phenotype. This is a theory that was first described by Fried and colleagues, and it describes reasons that age-related cellular and physiologic changes lead to impaired system processes and loss of homeostatic capability. It's based off of the cardiovascular health study, and it's determined when 3 or more of the following criteria are present: self-reported exhaustion, unintentional weight loss, weakened grip strength, slow walking speed, low physical activity. The frailty phenotype is one of the most used frailty assessment tools in surgery, and it has been validated. This is a table here that just illustrates a little bit more precisely how you meet these criteria. And once again, if you have 3 or more, you're considered frail. All of the criteria are objective measures except for exhaustion, which is self-reported. But basically, for all of the criteria, if you're in approximately the lowest 20% of the population, then you're considered frail. This is the accumulation of deficits theory that was developed by Rockwood. And this theory proposes that loss of function in multiple domains will lead to increased vulnerability. And some of the domains they describe are medical, social, functional domains. They also developed a tool to assess frailty that is based off of this theory, It's called the Frailty Index of Accumulation Deficits, or FICD. It's a 92 variable assessment tool where essentially you add up all of the positive points that a patient has and you divide it by 92 variables and you get this index score. But as you can imagine, a 92 variable assessment tool is kind of cumbersome and time consuming and not really practical for everyday use. So I would be remiss if I didn't mention this last third main approach to measuring or assessing frailty. It's the comprehensive geriatric assessment. This is actually the gold standard. Um, it's a process that involves performing a global review of patients' medical, functional, psychological, cognitive, and social well-being through a battery of standardized, validated assessment instruments. It's been shown to be associated with improved survival, functional status, and identification of deficits that we don't typically unveil in routine medical consultation. And it's actually what's recommended by the International Society of Geriatric Oncology and the National Comprehensive Cancer Network. But it's very resource intensive and time consuming. And because of that, it's hindered its widespread implementation. So can we prospectively screen large populations of predominantly robust patients to inform real-time clinical decisions? And the answer is yes. There's a tool called the Risk Analysis Index. And this tool was also converted into a clinical risk analysis index, and it's shown to have excellent correlation with the original RAI. It's a 14-item survey, and it assesses the following variables. It looks at age, sex, unintentional weight loss, poor appetite, cognitive impairment. It looks at 3 ADLs, so mobility, toileting, and hygiene. Where a patient lives becomes important. So are they independent? Do they live in assisted living? Do they have renal insufficiency, congestive heart failure, shortness of breath, or any history of cancer not in remission? This is important because it was designed to be administered by a nurse, an APP, or an MD, and it takes less than 2 minutes to complete. It's been validated in a cohort of over 6,000 patients at the Omaha VA from 2011 to 2014. And essentially, you get a score between 0 and up. And if you're 0 to 15, you're considered robust. Anything higher than 15 is associated with increased frailty. So I think this is a really important tool because it's been shown to predict 180-day mortality. So as you can see in the graph on the right, the blue line, it's a little bit small, but the blue line are robust patients. Green is moderately frail, and black and purple are moderate and severe frailty, respectively. And as you can see, as your frailty scores increase, your length of survival decreases exponentially. It was also shown to predict surgical outcomes in a cohort of patients who were undergoing major abdominal surgery. And you can see that as the RAI score increased, 30-day mortality increased, mean length of stay increased, and so did complication rate. So to look at this a little bit further, you can see here in this table that for the entire cohort, for all surgeries, the RAIC score was predictive of 30, 180-day, and 365-day mortality. So as patients went from robust to severe frailty, there was an increased percentage of death at all time points. They also took the time to break this down and look at complications. So they looked at all surgical complications, but they did exclude surgical site infection and urinary tract infections. They looked also specifically at Clavien-Dindo grade 4 complications. And basically what this means is this is just a surgical complication that is considered to be life-threatening and requires ICU management. And what they found is that all complications increased as frailty went up, and Clavien-Dindo grade 4 complications were more prevalent in our more frail patients. So this tool is currently being used for preoperative screening at the University of Pittsburgh, the VA Pittsburgh Healthcare, and several other private and VA hospitals across the country. The last tool I want to mention, just because it's going to come up in some of the studies that I mentioned, is the G8 screening tool. This is a really also another really simple and easy to use tool that has been validated. And basically, this looks at 8 different domains, and you get a score of 0 to 17. If your score is 15 or higher, you're considered not frail. 14 or lower is frail. So the lower your score, the more frail you are. And it's been associated with surgical complications as well as prolonged hospital stay, delirium, and higher 1-year mortality. So this brings us to frailty and head and neck cancer outcomes specifically. So I think, a lot of the general literature on frailty may be applicable to elderly head and neck cancer patients, but I think it's really important to specifically look at our patient population. We know that head and neck cancer involves the upper aerodigestive tract. So these patients become uniquely vulnerable to dysphagia, aspiration, and malnutrition, simply due to the physical effect of tumor burden. All of this can be exacerbated by subsequent treatment modalities, which may in turn enhance the effects of frailty, making these patients particularly vulnerable. So this is a nationwide study. It looked at over 150,000 surgical patients. They were undergoing ablative surgery for malignant oral cavity, pharyngeal, hypopharyngeal, and oropharyngeal neoplasms. And they studied patients from 2001 to 2010. And the point of the study was they wanted to see if there was a relationship between frailty and comorbidity in hospital mortality, postoperative complication, length of hospital stay, and cost of head and neck cancer care. And so what did they find? Well, I think it's important to note that when they screened all of their patients, the majority of patients were robust. It was a very small number that were frail. So 7.6% of their population were frail. But it was significantly associated with advanced comorbidity, discharge to short-term facility, in-hospital death, postoperative complication, increased length of stay, and increased cost. And I thought it was really interesting because when they compared frailty and advanced comorbidity separately, frailty was shown to be associated with a higher odds of surgical complication and cost than comorbidity alone. So I think what this illustrates is just that comorbidity cannot serve as a proxy for frailty. There was another study. It was a retrospective analysis of more than 1,100 patients who underwent major head and neck surgery. This came from the American College of Surgeons National Surgical Quality Improvement Program database. And the study sought out to see if there was an association between frailty and Clavien-Dindo grade 4 and grade 5 complications after major head and neck surgery. So as I mentioned earlier, Clavien-Dindo grade 4 is an ICU level complication, whereas Clavien-Dindo grade 5 is mortality. So what did they find? This study showed that mortality and morbidity increased as frailty increased. Showed it on the graph on the side. And it also showed a significant relationship between frailty and Clavien-Dindo grade 4. So as patients went from not frail to most frail, the percentage of Clavien-Dindo grade 4 increased. It also trended, there was a trend of towards increased Clavien-Dindo grade 5, but it did not reach significance, and they also didn't have enough patients in that subgroup to really do a proper analysis. They took this a little bit further and they performed a subgroup analysis where they wanted to separate patients out based off of what kind of procedure they were having. So they looked at classectomy, mandibulectomy, laryngectomy, pharyngectomy, and esophagectomy separately. And what they found is that when for patients who underwent glossectomy, mandibulectomy, and laryngectomy, frailty was significantly associated with Clavien-Dindo grade 4 complications. So I think we have established that frailty seems to be an important predictor of surgical outcomes in our head and neck cancer patients. But this brings us to another important question. Do we also need to be concerned about frailty in non-surgical head and neck cancer patients? And the answer is yes. There's not as much literature pertaining to head and neck cancer patients who are undergoing chemo or radiation looking at frailty. But there are two studies. There's a prospective cohort study that looked at all head and neck cancer patients. They were aged 65 years or older, and they were undergoing curative chemoradiation. In this study, they used that G8 screening tool that I went over earlier, and what it showed was that the G8 screening tool was predictive of survival at 36 months. So patients who were deemed vulnerable or frail, they had lower survival compared to non-frail patients. They did a follow-up study on the same cohort of individuals um, where they showed that frail patients reported lower health-related quality of life scores before, during, and after radiation with or without chemotherapy. And interestingly, what they found is that fit older individuals returned to their baseline health-related quality of life by the end of treatment, but it took frail patients 5 months to regain their original scores post-treatment. Additionally, frail patients suffered significantly lower functional status, higher symptom burden when they were compared to their robust counterparts. So this brings us to decision regret and shared decision making. It's clear that frailty affects the head and neck cancer patient outcomes, but it's important to understand if it actually affects or impacts decision regret in order to guide treatment decisions and see if it could possibly contribute to patient-centered low-value care. So first, let's talk about what is decision regret. Decision regret in healthcare has been defined as remorse or distress over a treatment decision. The concept of regret, it's thought to be the negative cognitively based emotion experience when realizing or imagining that the present situation would have been different if we acted differently. So it does seem to be a general phenomenon unrelated to specific demographic or population. So there is not a lot in the literature that's looking at decision regret pertaining to frailty and head and neck cancer specifically. But there are some studies that look at decision regret overall in patients undergoing any sort of surgical treatment. And there's a systematic review that's shown that risk factors most consistently associated with decision regret were post-treatment complications or adverse outcomes. And over time, it's thought that decisional regret may increase, particularly if we're not able to elucidate patients' values ahead of time. So this was a specific study that looked at head and neck cancer, oropharyngeal cancer survivors. They had almost 2,000 patients, and they did a survey, and 61% reported some degree of regret regarding their treatment choice. 25% of that 61% reported moderate to strong regret. And the strongest drivers of regret were difficulty swallowing, pain, and feelings of sadness. This was a prospective cohort study that looked at 274 patients undergoing head and neck cancer surgery. These surgeries included major surgery, so total laryngectomy, any sort of wide local excision that required a free flap or a regional reconstruction. They also included parotids, thyroids with lateral necks, and resections of cutaneous malignant neoplasms with neck dissection. Preoperative, moderate to severe depression was reported to be 9.6%. So that was without even considering if these patients were frail or not. So about 10% of our patient population is predicted to have some level of depression. That depression increased when we looked from baseline when we looked 6 months when they looked 6 months postoperatively. 26.7% of patients reported moderate to severe decision regret, and higher frailty scores were associated with depression, and increased depression was associated with decision regret. So this brings us to the importance of shared decision making and whether or not we as physicians can predict outcomes and preferences. So, physicians' ability to predict survival is actually not very good. It's about a 10 to 30% accuracy rate, and we tend to overestimate survival by a factor of 2 to 5. And it's been thought that the longer we're involved in the care of a patient, the more likely we are to overestimate these predictions. So I also wanted to look and see, is there a disconnect between provider and patient perception of quality of life? And there have been a couple of studies that looked at this. And it seems that as providers, we tend to underestimate the severity of pain associated with treatment. And there was a study that compared quality of life considerations in patients who underwent laryngectomy. And physicians thought that, communication impairment and their self-image, the patient's self-image, were the most important. But patients said that the disruption of their social activities were what was most important. There was another study where they surveyed healthcare providers, and 46% of patients assumed that laryngectomy patients would be willing to compromise their survival if they could have their voice back or their preoperative quality of life. But in reality, actually, only 20% of patients express that preference. So I think what this illustrates is that physicians and patients' perceptions often don't align with respect to treatment. So I think it's really imperative that we explore patients' values and goals through shared decision making. Curative intent therapy, it's often associated with persistent treatment related effects, and this can limit patients' function, their autonomy, and their quality of life. And in the setting of pretreatment frailty, the sequelae of treatment, whether it's surgical, non surgical, or both, can be more harmful if the functional status is unacceptable to the patient, even if we're able to achieve cure and survival is increased. That's not to say that standard care of therapy should never be considered for frail patients, specifically those with advanced stage disease. I just think that the side effects and the risk of treatment failure have to be in line with the patient's values. And if patients express unachievable goals, it's our responsibility as providers to, um, redirect them and guide them and provide them with comprehensive palliative and support services. So I want to just go back, revisit this case presentation that we started with. So this is just a reminder of our patient. And before I go over his clinical course, I just wanted to use some of the tools that we discussed. So I calculated his frailty based off of the G8, the RAIC, and the Freed Frailty Index, and this patient is considered frail by all of those measures. There's another useful tool that you can find at the website that I provided there. It's a life expectancy calculator. It's super easy to use. And it asks you questions like, where do patients live? Do they have heart failure? How old are they? And it can give you an estimation of their 6-month mortality. And so I was just curious. I did that for this patient, and his 6-month mortality was 49, estimated to be 49 to 62%. So what happened to him? He underwent a total laryngectomy. The decision was made by, I think it was his daughter, who was his healthcare proxy. He had bilateral neck dissections, a pec flap, and then he had a very complicated postoperative course. He was in the hospital with us for 4 weeks. He had delirium and hypertension, was in and out of the ICU. He had a pharyngocutaneous fistula. He underwent a second flap, had persistence of that fistula. He ended up getting a G tube. He went back to his nursing home eventually, but he was readmitted several times for pneumonia. The pharyngocutaneous fistula finally did close 12 weeks postoperatively, but he wasn't strong enough to undergo radiation therapy. So how can we possibly do better or standardize frailty into our clinical practice? And I think one way we can do this is by taking a pre-treatment timeout, whether it's surgical or non-surgical. And I think this is important because there are certain places, as I mentioned earlier, like the University of Pittsburgh and the VA Pittsburgh Healthcare, and some other VA hospital systems throughout the country that are doing pre-surgical timeouts. but they're not including head and neck cancer patients who are undergoing radiation or chemotherapy. I think that by implementing this for all treatment could be, really impactful. And this is kind of the global view of how you could implement such a screening tool. Basically, you would screen all of your patients, and the point would be to risk stratify. I predict similarly, probably the majority of our patients would be robust, but we would have a handful that would be frail. Um, and if they were robust, they would go into the standard of care pathway. And if they were frail, you would assess their 6-month mortality. You would have goals of care discussion and shared decision making. And if they still desired standard of care treatment, you could enroll them in prehabilitation. I just want to briefly talk about what is prehabilitation. So cancer prehabilitation is on the continuum of care that occurs between the time of diagnosis and the beginning of acute treatment. There is a lot of data and literature about cancer rehabilitation, but there's no standard program. Everybody kind of does it a little bit differently. You can have unimodal or multimodal targeted interventions, but the multimodal targeted interventions have shown to be the most effective. And what they can include a variety of domains, but some of those domains include physical, nutritional, psychosocial well-being, and smoking cessation. And the purpose is to prevent or reduce the severity of anticipated treatment-related impairments. And these programs, implemented typically 2 to 3 weeks before treatment, have been shown to decrease morbidity, improve physical and psychological health outcomes, decrease hospital readmission, and reduce indirect and direct healthcare costs. So this brings me to sort of my proposal of how I think that we could implement this here. I think it's a ripe opportunity to kind of look at frailty, how frailty screening can impact our entire head and neck cancer population, and also to look at decision regret, something that hasn't really been done in the literature. So I think it would be great if we could implement universal frailty screening using this RAIC built into EPIC and start to assess decision regret using the DRS scale, which is a 5-item scale in post-treatment patients, and start with a retrospective analysis over the last 5 years, looking at the pretreatment variables would be frailty, and then some post-treatment variables such as disease-free survival, overall survival, length of stay, cost of treatment, discharge to short-term facility, in-hospital death, and post-treatment complications. I think it'd be interesting to continue this prospective data collection and then hopefully implement a pre-treatment screening where we could risk stratify our patients as frail or robust. And for the frail patients, calculate their 6-month mortality, engage them in shared decision making, and prehabilitate those who choose standard of care treatment. And so, with all of this in mind, the goals would be to improve post-treatment outcomes, increase patient satisfaction, and reduce decision regret, and reduce low-value care. And so, in conclusion, I think it's important to emphasize that frailty screening is not meant to totally do away with or abandon our standards of care. It's simply a tool we can use to pause and assess expectations, and it provides us with an opportunity to be proactive rather than reactive. So I will leave you with this quote from Dov Seidman, author of the book Why How We Do Anything Means Everything. When you press the pause button on a machine, it stops. But when you press the pause button on human beings, they start. You start to reflect, you start to rethink your assumptions, you start to reimagine what is possible, and more importantly, you start to reconnect with your most deeply held beliefs. Once you've done that, you can begin to reimagine a better path. Thank you.
One question that I have, and this might be more for our head and neck staff. Do you have like any patient advocates to sort of help with expectations, like maybe a laryngectomy patient that patients who are supposed to undergo laryngectomy can like talk to? Because I know on the oncology side, they have patients with cochlear implants and other surgeries that they can like talk to and sort of figure out what to expect.
I mean, we do routinely get our patients into CPs and many of the plans, and so the videos of what these CPs would be like, try to, I'll try to repeat things over and over. So that it is more often. So yeah,
Yeah, they also have a list of, like patient advocacy groups, also patients who we treated in the past who volunteered to talk about the potential laryngectomy patient candidates. So they have a wealth of resources, and obviously we also have spent a lot of time with patient education, and then we try to get everybody involved pre-treatment. That's why we really emphasize rehabilitation, like you said, consultation to not just speech language, but nutrition, lymphedema therapy, dental oncology, everybody. Yes, Dave.
I thought the regret study was interesting. I wondered, did they talk about regret to not treat as well? I wasn't sure if that came up or if it was just regret for treatment.
I know it's just regret for treatment, but that is an interesting point.
Yes.
Yeah, no, thank you for that amazing presentation. I had a question about the general things that go into the Frailty index. How many of those are modifiable things? Or are those things that are all just, they are what they are?
Based off of that RAIC index.
Or any of the indexes that you had mentioned. I know one of those 92 variables is a lot.
I think the things that are modifiable are basically like nutritional status. Obviously, we can't modify age, we can't modify cognitive impairment, but also just like for cognitive impairment, I guess psychosocial well-being and just making sure that people have the support services intact.
Danielle, that was just an outstanding lecture. I just like how evidence-based it was and all of it. And it really brought with so much and sees that some kind of peaceful manner compared to other types of cancer. And what David's brought up is an important thing is not to treat, because you mentioned the one patient that had a tracheotomy, regretful, yet it changes so quickly. What is it like to be suffocating? And it's not a good situation. And it speaks to the lack of palliation options we have for so many of our patients when they're robbed of their basic functions of speech, swallowing, eating, breathing. And hopefully in the future, we get better options, whether it's immunotherapy or something else, because chemoradiation is actually more toxic than surgery. Many of our patients that were not surgical candidates, surgery is a better option for them.
Yeah, I thought that was why I was really interested.
Hey, Danielle, they're asking that you repeat the main question before you answer from Teams. Yeah, if you could just kind of recap the question and then before you answer.
Oh, sorry. So Dr. Scharf was just saying that, we don't have a lot of good palliative options for our patients. And so it's easy to sort of have regret after you do something, but what if you didn't do it? Would you also have that regret? And I had that same, and that chemotherapy and radiation are often more toxic. And so that's why I really wanted to look at frailty in that population, because most of the literature and especially the interventions focus on our surgical patients. But I think it's equally, if not more important, to implement it for patients who are undergoing radiation or chemotherapy. And I mean, I struggled with that day in clinic myself, because I remember he begged me to do the trach, and then I felt terrible that he was crying in my office and told me he would rather die. But made me feel like maybe I didn't do a great job of explaining what it meant to live the trach. But I also think hindsight's always 20/20.
And I'm sure decision regret evolves over time,
Yeah,
right? Depending on the timing from the treatment.
Yeah.
Yes.
Yeah, I echo what Joe said. I think that was a great talk. And frankly, I think it highlights an area as a system that we do very poorly in managing. The compelling graph that I recall initially, I think it was a more systems approach, where you looked at the different countries and how much costs are spent in the final year of life in comparison to other countries. And I'm curious, all countries have head and neck cancer, whether you saw in your research, whether they do anything differently or better with respect to frailty and decision-making, shared decision-making, because undeniably, they're probably not treating some patients that we're treating. And so are they doing anything differently? Or I know coming from Canada, they just don't treat them.
Yeah.
But what other things are in place?
The main takeaway from, oh, sorry, I keep forgetting to repeat the question. So we're looking back at this graph and commenting how the US does a lot worse than other developed countries, and what are they doing differently than we're doing. I think the main takeaway I got was that we have sort of trended towards being much more aggressive, and they focus very much on palliation. Now, those studies, once again, they didn't look at decision regret or, how those patients suffered. So I don't have a great answer for whether or not they're better at engaging in shared decision making and their patients are happier. But the overall message was just that we've become more aggressive, and they sort of lean more towards palliation.
Danielle has a great talk, super informative. Two questions. One is the survival studies you referenced. They control for disease staging.
Yeah, the studies that I looked at, they did control for disease stage and type. Oh, the question was, the studies that looked at survival, did they control for disease stage and type? And they did. Some of them, like they did subgroup analyses for the different types of head and neck cancer. Some of them lumped them all together and just grouped them by stage. Yeah, so I was actually, I was interested in that. The question was, what do I think our ability is to be able to prehabilitate patients? The challenge with that is that they are doing prehabilitation, but there's really no standardization of it. So everybody who does it a little bit differently. From what I could tell and what the literature shows is that they don't really show how patients can progress in, like, go from baby being moderately frail to mildly frail. But they show that these patients they talk a lot about exercise regimens and nutritional as well as psychosocial support. And they just talk about how starting that 2 to 3 weeks prior to any treatment can really help them develop really good patterns that they can carry on throughout the course of the rest of their life and their treatment. So I don't know if it modifies their frailty score so much, so to speak, as it does just really sort of give them the support system that they need and the tools that they need to kind of help them get through. But that would be another interesting thing to look at.
I guess how relevant is that though? Your question, modifying their frailty score, that's not what we look for modification.
Yeah, that's true.
Maybe if you have a frailty score, it's still the same, but you rehabilitate them.
Yeah.
There's a great NISQIP ACS preoperative calculator where you enter different indices, metrics, and they calculate what your risk of postoperative complications are. It would be great to fit a frailty index so you have kind of real-time decision-making with patients.
Yeah, that would be.
And I think that's probably a more current iteration, more relevant iteration than what the ACS has in terms of.
Yeah.
With all of your research, was there a specific metric or test that you find to be the most promising for actual clinical utility? Was there a favorite?
I think that RAIC seems to be the most easy to use. The G8 is good too, but the one that's actually being used and implemented in clinical practice and in these timeouts is the RAIC, and it's just been studied more robustly than the other ones, in our patient population. So that's sort of the one that I would lean towards. And it's easy enough to use. Like they say under 2 minutes, but I think some people say that you can do it in like 30 seconds to 45 seconds. It's pretty quick.
I wondered if people are using, like I know there's been a big push to use a lot of these educational tools, whether it's for depression or frailty. And I wonder if you've seen a push at all for surgeons to actually incorporate this in patient counseling. I know I've worked with a lot of surgeons who will quote studies, and I think that helps patients to have a better understanding of chances of recurrence or things along that nature. But I didn't know if people have seen it used at all clinically.
Well, I haven't. I think, one of the things I've thought a lot about is I think we do, and I've, like I said in the beginning, I've sat through a lot of these discussions, and I think part of the disconnect is that as providers, we're telling you, oh, you have a 50% chance of survival. Well, if you told me that, I'd probably take that 50% chance because it's 50-50. But, it's hard, like some people alluded to earlier, it's really hard to truly understand what you're going to go through until you've already gone through it. So I don't know if there's a way to fully, I don't think patients will ever fully understand. I think we do the best we can, but numbers and facts, they sound good, but then post-operatively, if patients aren't speaking the way they thought they were going to be, it doesn't necessarily correlate with what they were expecting.
All right. Thank you so much, everyone. That was a great discussion, great presentation. Great job.